Welcome to Quantum Photonics. So, power defined as an asymmetric control of valued resources profoundly impacts most human interactions, including those within the healthcare settings. Understanding this power dynamic, particularly in critical doctor patient relationships, is essential but challenging to study using real world data. However, a distinctive dataset from the U.S. Military Emergency Departments offers a unique insight into these dynamics. In our future discussion, we will delve into a study involving 1.5 million quasi random assignments in these emergency departments, examining how differences in military ranks, an indicator of power differentials, affect physician behavior and patient outcomes. And to bring this topic to us, there are two research papers done by his group. And in fact, this is really very, very interesting because the implications cover a lot of power dynamics universally. So, Dr. Stephen Schwab is an organizational health economist and an assistant professor of management at the University of Texas at San Antonio. His research centers around the workforce management and organizational performance with a specific focus on the role of interpersonal relationships play in maximizing performance. He has a PhD in managerial science and applied economics from UPenn, Wharton School of Business, and a master's degree in health and business administration from Baylor University. He is also a retired Army Lieutenant Colonel with over 21 years of professional and leadership experience. He served as the Chief Financial Officer of the Brooke Army Medical Center, a Level 1 trauma center, and the Department of Defense's largest hospital. He also served as the Chief Financial Officer for the Walter Reed Army Institute of Research, the Department of Defense's largest biomedical research laboratory. He continues to partner with the military health system and the Geneva Foundation to advance military medicine through research, development, and education. So here I bring to you our special guest speaker, Dr. Stephen Schwab. Steve, welcome to Quantum Photonics.
Thank you so much. Thanks for the introduction and the great music to start with. So I thought I would just start with a thought exercise here. And I just, you can take a moment, put something in the chat if you feel like it, or just think internally. But if you had to define power, what is power? Um, and that's part of the challenge that my co-author Vinny Singh and I were thinking about as we started this project. To give you a little background, the way this started is that I was at the time still in the military, and part of the research that I was doing was, well, I should say I'm still doing, is how do we reduce variation in care, right? So there's a lot of literature that goes back many years that shows that if you go to a doctor in McAllen, Texas, you might get some different level of care than if you go to a doctor in, say, Grand Junction City, Colorado, which were the two major areas that were mentioned. First by Atul Gawande in a pretty famous paper, and then later by President Obama when he was storming for the Affordable Care Act. Now, a lot of my background was really thinking about interpersonal relationships, and so Vinny, who's a behavioral economist at Carnegie Mellon, and I were talking one day about how interpersonal relationships could potentially be affecting this care, and a lot of the work I've done has to do with continuity of care and trust, and we were just sitting there thinking, like, we know, at least there's some evidence on how things like racial and gender concordance come in, but there are a lot of things that go in interpersonal relationships. And as we were having this discussion, we kind of came to this conclusion that status might matter, how the physician perceives the patient may actually play a role in the care that a patient receives. And we wanted to set out to study that. And so what I'll do is I'll get into now thinking about what is power, and how that potentially shapes behavior, especially within the healthcare industry or in the healthcare context. And thank you. I know you pinned my slides up top, so if anyone wants to follow along, I'll be going through those slides, at least generally. Um, Although I am hard person to keep on specific topics, so we'll see how it goes. Um, okay. Oh, I should always say, if you look at slide 2, these are my views. These aren't the views of the Department of Defense or the U.S. government or Defense Health Agency. Um, so the 15-second summary, if you have to leave early and just want to hear what is the conclusion, it's that power imbalances between the doctor and patient affect patient care. And when we are able to diminish these power imbalances, we get additional effort. And I'll talk a little bit about how we measure effort, which again, like power, is very difficult to measure. Um, so we get a little bit more effort and resources expended on the patient. And this seems to have some positive effects for the patients in terms of, reducing, say, hospital admissions or readmissions. Uh, so I asked you to think about what is power. And I'm going to give you the sort of definition that we use in the paper, which is very broad. And it comes out of the primarily psychology literature. And its broadest sense, power is the asymmetric control over valued resources. So somebody has more control over resources than someone else. Now, this could include wealth, it can include information, it could include decision rights, authority, status, and we could go on and on. I presented this to a few different audiences, and if you present to sociologists, you get a little bit of different definition of power than when you're talking to economists. But this sort of seems to be the running theme throughout it, is that this is about asymmetric control. Now, power is going to affect everything. So the psychology literature talks about how power affects the way people perceive information and then how it gets incorporated into decisions. Um, Economists like to talk about non-pecuniary utility to the decision maker, which is basically some sort of advantage, joy. Utility is this like broad feature for things that we generally like. And they, through having power, we get this utility that's not just about money, but it's about other things. And sometimes this makes people act differently, and at times suboptimally. Um, Now, power exists everywhere, whether it's my relationship with my friends or coworkers, but it's particularly important when one individual is making decisions on behalf of another, and even more so when we're going to think about legal authority. So, for instance, police officers have a level of power that is given to them by the state. And so we can think about power differentials between, say, the police and your average citizen. Same thing in schools, right? So I've got 3 kids, varying in age from second through 8th grade, and their teachers have a certain level of power, and the principals have power. And obviously, as a parent, I have a certain level of power, although I'm not sure my kids believe that. Um, Now, in medicine, there's also power because physicians get to make decisions. And while there are certain laws that allow individuals to have autonomy on what's done to their body, at the end of the day, if I go to a physician and say I want name the prescription drug, I can't do that on my own. The law has provided certain aspects of that through licensure laws and through um, other means of regulatory restrictions, so that only doctors can do certain things. And not everyone can say they're a doctor, right? So we have, you have to get licensed through the state. And what this does is it means that whenever I go see the doctor, regardless of my wealth, regardless of my education, there is always this asymmetric control because the physician can make certain decisions on my behalf, or not make those decisions that I would like them to make, such as potentially prescribing a certain drug. Um, Now, power is also important when we have what we call information asymmetry. So some people know more than others. And again, in the doctor patient relationship, we're going to see this a lot because doctors have gone to medical school and they've got a lot of information about maybe the options that are available that a patient might not have. And so when the doctor says, hey, I think we should take course A, maybe they give me an alternative of course B, but there could be C, D, and E that they're not telling me, maybe because they're not thinking of it or because they're rushed for time, for a variety of reasons, but they have information that I may not. And then we have what we call principal agent issues, meaning the doctor is supposed to be working on my behalf, but they have other incentives as well, right? They have financial incentives. They may need to, finish at a certain time, and I'm their last appointment of the day. Lots of things go on when we think about when somebody is making decisions on behalf of another. Um, okay, so I'm on slide 6 now. If you're trying to follow along, the challenge with actually looking at power is really twofold. So, one is that we have this unique expectation of the doctor patient relationship that doctors are purely altruistic. And, well, most doctors I've met are pretty altruistic people, and I think very highly of physicians in general. It's probably unrealistic to think that anybody is completely altruistic, right? People have their own personal lives and things going on and their own incentives. Um, and then the second and maybe the bigger issue, if we're going to try and look at this through empirical research, is that how do we actually isolate the effects of power from everything else, including the source of power on medical care? Again, because power is this ephemeral sort of theoretical concept, it's really hard to measure like what is power. Um, Yet we do have some evidence that uh, power imbalances exist and that they in fact care. There's qualitative evidence through research and discussions, but there's also some racial concordance studies, and I'm going to point to one by Marcel Alsan and co-authors that ran a randomized control trial in Oakland. So they got really poor black men and they got them to come to like a pop-up clinic for some preventive care. So think things like vaccinations. Um, and they randomized these black men to either see a black doctor or a white doctor. Um, and what they saw is the uptake of a lot of preventive care, specifically flu vaccines, was much higher when there was this racial concordance. So a black doctor with um, a black patient. And this, it may make sense if you think about trust and communication and some of the other issues that go on in these patient physician interactions. So we're not the first to think about this, but that's talking about this racial concordance that we can think about trust, and they have some ways of trying to get at that. But it's not necessarily just thinking about power. And so, we're going to be able to actually do something to get at this. And that's really, I think, the key contribution of this paper. So on slide 7, it talks a little bit about the military health system where we're going to get data. And so if you're not familiar, this is different than the Veterans Health Administration. So people a lot of times are very familiar with the VA, but the military actually runs its own healthcare system for active duty military, for their families, for retired military, and for their families primarily. And so this is about 51 inpatient hospitals and another about 400 clinics. And active duty military are basically required to seek their care in one of these military hospitals that are staffed by a mix of government civilian and active duty military physicians. So about 70% of the physicians in the system are actually active duty military, Army, Navy, Air Force doctors. Um, Now, what's interesting about the military is it's a very hierarchical organization, and every service member wears an observable rank. Um, and so that rank confers a certain level of authority given to that individual. Um, it also confers a little bit of status, right? So maybe somebody more senior might have more status outside of even their formal authority, and we'll talk about that towards the end of the presentation. But what's important is that both the doctor and the patient have these very observable ranks, which are going to allow us to think about what is the difference in power. Um, Let me go to some anecdotal evidence. So if you go to slide 9, I'm going to give you just a couple of quotes that I received while doing some background for this research to say, hey, rank may matter. And so this came from the chief of one of the military emergency departments that said, you're supposed to be blind to the military rank of the patient, but human nature takes over. You're just a little bit more careful when the stakes are high. Somebody else showed me a text that said, hey, know that this colonel is coming in and to not have him wait. Could you help facilitate getting a specialist involved if he needs something? So again, just some anecdotal quotes, and actually we got a lot more as we talked to people about this research saying, oh yeah, we see this, we observe these sort of small things, right? Hey, push this person to the front of the line. Hey, make sure you take care of this person pretty routinely. Now, I think some of the press that's come along with this has kind of framed the study as if we're comparing care across different ranks. And I want to be clear that that's not what we're doing in this study. If we were to try to compare the care that, say, a general gets to the care that a private gets, there are all kinds of confounders. And it's really not an easy thing to study and not something that we were looking to get at. We wanted to know outside of a patient's rank what happens when the power differentials are different. So if you look at slide 10, we try to have a figure here that shows it. So we're going to look at a patient's rate compared to their doctor rate. And so think about this, that we have two patients who are say a major, which for the Army is the fourth officer rank, and two of them come into the emergency department at the same time. And because emergency departments randomly assign patients to physicians, whoever happens to be available at the moment, one major is said, hey, you're going to go see Dr. A, and that doctor is a lieutenant colonel. Lieutenant colonel is a more senior rank than a major. And so here, the doctor outranks the patient. But the second major comes in, and the doctor available for him is an Army captain. An Army captain is the third officer rank. And here, the major actually outranks the captain. So two majors come in. One outranks their doctor. One does not outrank their doctor. And so what we're going to do is we're going to try and compare what happens to these two patients when one outranks their doctor and the other doesn't. And we're going to do a bunch of econometric stuff to limit the effects of, say, differences in physician ranks and other covariates. Let me see. Uh, yeah. So I should specify here that regardless of whether a patient outranks their physician or not, the physician still has the power in the doctor-patient relationship. And the sort of example I like to give is if I was a lieutenant colonel in the Army, if I was flying in a helicopter and I outranked the pilot, which was typical, I did not have the authority to say, hey, I'm taking over to fly this helicopter, having never been trained on how to fly a helicopter in my life. And it's a similar thing in the doctor patient relationship. Just because somebody has higher rank does not mean that they can say, you will prescribe me X drug or you will order this test. The power still remains with the doctor. What we think happens is when the patient is a higher rank, maybe the amount of power is a little bit different. There's a little bit less power differential when the patient outranks the doctor. Now, if you look at slide 11, the way we're going to measure effort is we're going to use typical healthcare claims, and we're going to use something called a relative value unit. And you can just think about this as a way of aggregating total spending on a patient. Based on what the procedures that are done, they correspond to a certain amount of relative value units. And then we're also going to create a resource index that looks at a number of different types of things that go on the medical claims, including how many diagnosis codes are documented, the level of evaluation and management, which is a proxy for the physician's sort of thinking and considering effort. And then even things like the probability that somebody gets an opioid prescription, which occurs pretty frequently in the ED, although there's a lot of initiatives over the last number of years to try to limit those. Um, Okay, so I'm skipping here to slide 13. And if you want to follow along, there's just between slide 13 and 14, what I'm going to show you is that it is pretty random what rank a patient sees. And so these two majors that I was talking about come in, we've got a lot of evidence that it is quasi-random who the physician rank that they see. And slide 14 just shows you a balance table that we show in the paper that shows once you control for the patient's rank, really, and actually throwing physician's rank here, but it doesn't matter. We've done it both ways with and without. There's no differences in race, age, gender, or comorbidity scores. So basically, what the underlying health level is of the patients between those who outrank their doctor and who don't, or who do not. Slide 15 shows the empirical specification. I'm going to go ahead and skip on that and come to the results on page 16. And this is probably my favorite figure from the paper, and maybe from any of my papers, because what we're going to do here is we're going to show the difference between the patient's rank and the physician's rank. And so if you're not looking at it, we go from -5, meaning that the physician is at least 5 ranks higher than the patient, to the other side where the patient's at least 3 ranks higher than the physician. And what you get is a fairly straightforward difference that as the difference becomes closer to 0, from -5 to 0, the basically the amount of logged RVUs, so the amount of what we're using as a proxy for effort, shrinks. And then as the patient outranks the physician, it goes up. And if you were to aggregate these are statistically significant results. Um, uh, Slide 17 shows just basically all these different outcomes. So whether we're talking about relative value units or whether we're talking about this resource index, what we see is that there's about a 3% increase in what we're calling effort, or at least resources that are being expended on patients when they outrank their physician compared to patients that don't outrank their physician after controlling for things like the patient's rank, the provider's rank, the specific clinic they're going to, the time of the year when they come in. Um, the other, I guess, two important things I want to point out here are that we see a huge increase in opioid prescriptions when the patient outranks the physician. Now that might be because people are more demanding. We don't really know why that is. We could imagine that it's because of trust. When somebody's a higher rank, maybe there's some extra level of trust, and given the opioid epidemic, maybe these physicians are more willing to prescribe those. But I want to be careful because we don't actually see the conversation that's going on. All we know is that these prescriptions are being prescribed more. The other, I think, important piece here is we look at both hospital admissions from the emergency department. So you can think that somebody comes in and rather than sending them home, they admit them to the hospital. And we don't see a difference there, which says, hey, look, on the margin, right, whether somebody needs to be admitted to the hospital is probably much more about the underlying, right, were you in a car accident or do you have lower back pain? Um, Even though we do control for the major diagnosis, I should say. But what we see is after they're sent home, do they need to be admitted to the hospital within the next 30 days? And we get a pretty stark decrease, somewhere on the neighborhood of, I want to say it's about 15% to put it in percent. Risk, it's a negative 0.019 standardized, so standard deviations. Um, Reduced probability of being admitted to the hospital within the next 30 days for a patient that outranks their physician. This is statistically significant at the 90%. It's not quite at the 95. So we think this is at least suggestive evidence that it's not just wasted effort, that this is actually preventing something at least over the next 30 days. Um, another test. So this was one test, but I teach statistics, and I always tell my students that you should never rely on one paper or one test because things, there are always confounders and there's things we don't think about. So we run a number of tests in this paper. And the second test we look at are people that are either about to be or were just promoted. So we take here within a single rank. So let's take somebody who's going to be promoted from sergeant to staff sergeant. So this is for the Army, the fifth enlisted rank to the sixth enlisted rank, although we do this across all services. But we say, okay, well, we've got all these staff sergeants in our sample, and we know when they got promoted from sergeant to staff sergeant. And so we're going to look at the everybody who's made it to staff sergeant. So we're comparing apples to apples, and we're going to say, okay, if you happen to need to go to the emergency department in the year before you got promoted versus you happen to go to the ER in the year after you got promoted, and we're going to compare these two things. And we're actually going to look within a physician. So we're going to do what's called a physician fixed effect. In economics literature, fixed effect has some different terms depending on your discipline. But basically, we're going to look and aggregate within physicians what happens. And what we see is that the overall number of RVUs goes up by about 1% if the patient comes in right after they're promoted versus before they're promoted. And if you're looking on slide 18, what you can see is this is pretty stark, right? It occurs pretty right away when this promotion occurs. So whether you look 3 months back, 6 months back, 9 months back, it's pretty even number of RVUs. And then once you go up 3 months, in that first quarter year, it goes up by about 1% and stays there over the course of that next year. So here we're able to deal with things like, oh, well, instead of, we're not necessarily comparing apples to apples. If you worry about the patient outranking their physician, then the physician is by nature a junior rank, even though we control for it. Here we're able to look at the physician's rank isn't changed. It's the same physician. They're just seeing some patients who are about to get promoted and some that had already been promoted. The next thing we do is we were interested in how does this correlate with other markers of power in society? And so specifically, we're going to look at race and gender. And so if you look on slide 20, the top row deals with race. So on the left, we've got all of our black and white physicians. And then in the middle, white physicians, and on the right, black physicians. And we're running this triple interaction model. And what we see is the black physicians tend to treat lower power white and black patients about the same. There doesn't seem to be a big difference where white physicians do have a difference in the way they treat low power white and black patients. Black physicians are extremely responsive, though, to high power black patients. And again, we don't know the why. We think this is an interesting area for further research. One hypothesis could be that a black physician knows how hard it is to succeed given all of the challenges and racism and other parts of our society. And when they see a senior black patient, they have it creates an additional sort of level of status or respect. But again, or it could come out to something to do with communications, because now they're together both on race, but also potentially on levels of education or some other metric. We don't really know, but we do see this. On the bottom column on this figure, or bottom row on this figure, what we see is the same thing by gender. And what we'll see is that male physicians give female patients more resources regardless of their rank. However, they're much more responsive to high rank female patients. Females tend to be pretty consistent with a little bit more for high ranking female patients. And something I want to point out, because I get this question a lot, is this, pregnancy tests or something like that? And we've tried ruling those out. We've excluded anything to do with pregnancies. And it just seems for some reason, male doctors are giving more resources to female patients regardless of the underlying health status, not just to deal with potential pregnancies or something like that. And again, the females, you do see a little bit more for the high power female, but certainly not nearly as stark as for the males. Again, we put this because we think it's very interesting and can generate some conversation, but I think there's a lot more research needs to be done on the sort of the heterogeneity, gender, race concordance, and how power interacts with those. Um, the last test that we're gonna show, or I'm gonna show you today, is on slide 21. And what this is we want to understand, is this coming from power, authority that the military conveys, or is there some status that comes along with the rank? And so one test we said is, okay, somebody who retires from the military, and take myself for example. I was a lieutenant colonel when I was in the military. I've since retired. Um, I my retired rank is still on my record, so somebody knows what it was, but they also know that I'm retired and that I have no actual military power anymore. Nobody has to salute me. Nobody, has to call me sir. That doesn't exist anymore. And so we looked at retirees, and we said, okay, well, if in fact it's a power, then when somebody retires, the effect should diminish. And if it's status, it should remain the same. And what we see is basically no change here. Once we interact here retirement with this indicator for whether somebody outranks their physician, we see that it's consistent in the 5 years before they retire, and it's consistent in the 5 years after they retire. And so we take this as, again, suggested evidence that this is really about a status effect, and it's not an authority effect. So I'll just end with some summary conclusions here. And so I think the important thing here is that we know from lots of research that there are inequities in care, and we think power disparities, whether that's through wealth or whether that's through status, is one channel that can drive inequities in care. And that power in our study is a complex combination of a lot of different things. So status, race, gender, levels of authority. You could even think about things like how outgoing somebody is, how trusting they are. Are they willing to sort of come in and say, "I want this from the doctor," or are they going to sit there and more be more passive rather than maybe more on the aggressive side in shared decision making. And again, all we're able to really look at is this overall difference and then interact a little bit with some of these things. We think this has lots of implications inside and outside of healthcare, particularly that people may not be aware of the power that they yield. So, I can think about, my own experience or experience of friends in the military, and certainly thinking, oh, I'm this rank, I'm going to get better care, never sort of went through my head. And so, we want to make sure that people are aware that in these everyday interactions, there potentially are sources of power that we're wielding, and thinking about tools that we can maybe be aware of and maybe combat this bias. So things like patient advocacy, physician training, letting physicians know what's going on, right? Showing them some data on what they're doing, maybe doing better patient physician matching or coming up with custom shared decision making aids can allow physicians to be aware of these dynamics so that they can be a little, or I say, reduce the inequities in care that they may be providing. With that, I'll say thank you, and I'm happy to stick around for a while and answer any questions you may have.
Yeah, thank you so much, Steve. And I would like to announce to the audience that we're opening the floor for questions. If you have questions or clarification to ask our speaker, please just raise your hand. We will bring you up the stage. And we have Nas here who raised his hand earlier. And anyway, I'd like to ask you, Steve. I think this study, or one of the studies that you had, mentioned about 1.5 million assignments. And what is the demography of these assignments? I mean, is it distributed all over the US? Yeah,
Yeah,
I would just like to ask that.
sure. Yeah, it's distributed all over the U.S. So there are military hospitals across the country. So Of 51 military hospitals, I believe 44 of them are in the US. Don't quote me on exact that number, but it's somewhere in the 40 different hospitals. And so they're going to be, there's three in Texas, there's a couple in California, DC, Portsmouth, New Hampshire, Virginia. So yeah, it's really nationwide. It's not every state that has a hospital, so it's certainly not as big as something like the VA that is really any major city you can find one, but you are finding throughout a broad swath of the country, and every major region has one. What do you think? The Midwest, the Northeast, the Northwest, California, South, Texas, all of these places have hospitals. The randomness, though, I will speak out. So the military, you could say, quasi randomly assigns people across the country, based on needs and job series and all that. The real quasi randomization that occurs here is when somebody shows up to the ED, they don't get to choose their physician, neither can the physician choose their patient. And so that's really where this 1.5 million observations really let you know that there's some randomness here that allows for us to get at some causal inference, is the fact that there's no sort of matching here between patients and physicians.
Yeah, thank you. So, the reason why I asked that question, because of course, if you distribute it all over the U.S., there are some different parts which
Mm-hmm.
it may be prone to, like, race bias,
Sure.
and not and well, I'm speaking in terms of not only in the military, because of course that is your frontier, really, but I just want to say an anecdote about our former speaker here who was doing research about AI. I don't know if you remember him, Bob and Darcel, Dr. Ishanu Chattopadhyay. He is already working as a professor in, I think, University of Chicago. And suddenly I saw him on Twitter, and he was saying, "Oh, I'm having a big problem here in the ER. I'm not treated very well. It's really bad." And he was on the hospital wherein he is already a faculty of, and yet
Mm-hmm.
he's not treated very well. And as you were doing your presentation, I was wondering, was it because Ishanu is Indian that he was not treated well? I mean, in uh, I would like to say fairly, in the ER department. So I was considering how is race affecting situations in different parts of the US, because there are parts that are dominated by white people and
Mm-hmm.
parts that are dominated by black people. Some parts maybe by, there are some, and even not dominated, but there are a lot of Hispanic people. So I was thinking about that. So yeah.
Yeah, I think it's a great point, and that's one of the reasons that we wanted to do the racial and gender interactions, because we do think that it's an important piece. What I will say is that there's a lot of evidence of racial bias in healthcare. I think that's pretty well documented, and even you can look at things like, I always forget if it was Venus Serena. I think it was Venus Williams and the issues that she had when she was giving birth, and almost dying from not being listened to, and certainly those things occur. The evidence that we have says that racial biases are less in the military, not non-existent by any stretch, but that it does the military does not have as many disparities based on racial characteristics. But I certainly think that it is not non-zero, and that we still have a lot of work to do. And certainly across the country, we see these things, at least anecdotally, like the one you mentioned, over and over. But there is a fair amount of research that documents it empirically and shows that race is highly correlated with disparities in care.
Yeah, thank you, Steve. So, I think your research is really very interesting, because it could stretch to other dimensions and lead to possible questions that would be, future papers that you have.
Yeah.
And I would like to mention that we had a former guest here, I think from Barcelona University, Dr. Emily Caspar. She had an experiment on doing the Milgram experiment on people actually, and she one of the findings that they had is that regardless of the rank is that if you give power to people, they have a tendency to abuse it. And that reminds me of a popular quotation which has been usually attributed to Abraham Lincoln, but now they said that it's not Lincoln who said this, but it says that everyone can stand adversity, but if you give a person power, you will see his real character. Any comments on that?
Yeah, I mean, I think you know we all wield different levels of power, right? And um, sometimes it's hard to understand the levels that we have. And certainly, there's the whole, you gave the quote, I guess, misattributed to Lincoln, but there's also, the whatever absolute power corrupts absolutely. Um, and I think there's some truth. But what I will say is, I think a lot of this is unintentional, right? So at least in our research with doctors, not to say that like there are no bad players as doctors, right? Doctors are people like anybody else, but I do think that a lot of this is not necessarily intentional. It's this implicit bias, which is you know is important for us to acknowledge because I think most of these providers, when you talk to them, they will tell you that they try to treat everyone the same. But then when you also get, sort of the thinking about it, they admit to, oh yeah, okay, like I showed you a couple of quotes that these things happen, and they acknowledge that these things do happen. Um, and the question is then, what can we do about it? How can we help people who have power to wield it more fairly, I guess, because we're not going to get rid of power dynamics, right? You could think about, oh, we're gonna like take all of these decisions out of the hands of doctors, and I do not think that would be a very good idea. I think that would be negative for most patients because most doctors, I think, do a pretty good job and most doctors have a lot more knowledge than the average person. The question is, okay, how do we get rid of some of these biases that are just part of human nature that we don't realize, what we have or how we wield it, and try to get people to be a little bit more deliberate about the decisions that they're making and understanding how they might be different based on the other person, right? The alter in that relationship. I don't know if that answers the question.
Yeah, thank you, Steve. So we give the chance to the speakers who came on stage here, Nas and Kevin, to ask their questions. Thank you for waiting patiently. And I think there are questions on the room chat, and probably Bob, if he can speak later on, he will read these questions. So in the meantime, I'd like to give the mic to Nas, who has been patiently waiting. Nas, I'd like to give the mic to you.
Thank you, Cecile. Thank you, Steve. Two quick questions. Number one, what criteria did you use to define power? And was the power of rank power a factor in patient receiving treatment? Obviously, a four-star general is not the same, treat is not the same as a very low rank.
Yeah, yeah, yeah. So this is a really key point, and thank you for asking this question. So what we do is we define power as the differential in rank between a patient and a provider, and most of our analysis are a binary. Does the patient outrank the provider? But all of our analysis are within patient rank. So again, we compare, say, two majors that come in. One outranks their physician, one does not, and we say that's reducing the power disparity. Or we say, if we want to do it in the non-binary, a major that comes in might be, say, one rank above a physician, and another major might be one rank below a physician. And so that's you could think a -1 versus a one, if when we're putting this into the mathematics of it. And so we're not ever comparing a major with a captain, or a general, like you said, a four-star general with a private. There's just so many things going on that you can't possibly run that evaluation, at least not in the way that we've done this. It's not enough to have random assignment because there's so much non-randomness to who gets promoted and underlying health and all these other things that go on. So we are only going to try and compare like to like. So two majors that come in, and we're looking at the difference in their rank. And so we're using it as a proxy for power to say, hey, if I'm rank 5 and I see someone that's rank 3, then I've got an additional power of 2. And we're going to do this in a way that allows, non-continuous, right? So discrete. So a power difference of 2 is not necessarily one different than a power difference of 1 or a power difference of 3. But we're going to say, okay, this is the effect of a power difference of 2. This is the effect of a power difference of -2, based on this proxy of differences in military ranks. Does that answer your question?
Yes, it does. Thank you very much.
Yeah, thank you, Nas. So, Kevin, it's your turn.
Oh yeah, hi, yeah, who yeah, I love the army. Yeah, I missed my calling, but yeah, I love the army. It's a long story, but my dad was Navy, but um, anyways, yeah, it's I thought of some things and researched some things. Maybe you can speak on. Like I thought of maybe potential solutions, like task shifting. So we redistributed tasks, from uh, among health work teams, workforce teams, when appropriate, from highly qualified health workers to health workers with, shorter training and fewer qualifications is one, and algorithmic support, implementing algorithms or decision support systems that can help, standardize care and reduce the influence of, biases. And I think you spoke of, increasing diversity, which is pretty obvious, and bias training. Just I think it's kind of general knowledge, but just to avoid favoritism and rank and patient advocacy. You know, um, and then transparent reporting and accountability. Some of the things I thought of and researched.
Yeah, these are great. So let me see if I can go through a few of these. Let me start with diversity, just because I think that one is probably the best solution and yet the most difficult solution. So we've got a major problem. This isn't necessarily military specific, but we have a major problem in the U.S. that we're not training enough doctors to begin with, and we don't have enough diversity within the doctors that we are training. So if you look at the proportions of doctors that are African American that are graduating now versus 30 years ago, it's a little bit more, but it's not a lot more. And so, unfortunately, that answer is going to take a generation to solve, if not more. So I think that would be the sort of best case scenario, but I don't think that is achievable in the short term. So moving back to some of the others, okay, so task shifting. And if I'm understanding, you're thinking about taking things that maybe an advanced practice provider or a physician extender, like a nurse practitioner or maybe a nurse could do, and taking that out of the hands of the doctor to start to maybe reduce the disparity in power. Am I understanding that correctly?
Yeah, exactly. Yeah,
Okay.
I think that's the gist of it. Yeah, the meat of it. Yeah.
Yeah. I think that's so. I think there is some thoughts towards doing that. Certainly, the use of physician extenders is being used in the military and civilian. I have some work I'm currently doing on differences. I think the challenge of that is if you know that this person only needs X, Y, Z, and that a nurse can do that or a nurse practitioner can do that. That's great. Oftentimes, you're dealing with uncertainty, and it's not somebody comes in with, let's say, chest pain. That could be gastric reflux, or that could be a heart attack. And so, a lot of the challenge is in the actual diagnosis. And so I think that becomes difficult with potentially the margin on which a lot of this happens. But certainly there are areas that we can look at it more. Um, and there is a lot of work being done on the use of physician extenders, primarily because we are very, very short on physicians over the next 10, 20, well, even currently, but especially over the next 10 or 20 years. The second, algorithmic support, I think this is a big one. and something that is being used uh, pretty heavily in healthcare are these decision-making aids. So clinical decision-making support. A lot of this comes into the health information technology. You put some information in, and I think it's helpful. But again, I don't think it's a panacea because these algorithms often depend on the information that the doctor can put into it. But if the doctor spends more time with their patient, they gather more information in order to document this. And then we have other issues with, say, physician burnout when you're asking them to put more and more into the computers. This goes for not just physicians, also nurses and other healthcare providers. That I think it's one tool that we should be thinking of. And I'll say one other thing on that. If anyone's interested, I would go to the 1% project. It's 1% tools to reduce healthcare costs. And the idea is there's no silver bullet, right? We're not going to do one thing that fixes healthcare. What we can do is a lot of things that might save 1% or reduce disparities by 1%. And when you aggregate these things up, they're pretty impactful. So that's one that I think can have some effect and is worth using, but we do have to be a little bit careful of the unintended consequences of, okay, we're giving more computers for the physician to look down at and fill things in rather than looking at the patient and actually listening. And then accountability. I think accountability is a big one. And it's not an accountability, in my mind, like, oh, we got to like get the bad performers or we need to like get some people. I think what it is that people are often unaware. And I'll give you another study. It doesn't do with power, but there's a study by John Kolstad out of UC Berkeley. I don't know, maybe 10 years ago. And he was looking at surgeons, I think it was heart surgeons. And these heart surgeons have a fair number of people um, that pass away during the operations, just the nature of a very risky surgery on a very sick population. Um, but what his study found was that letting physicians know, well, I should back up and say part of the problem is that when a patient dies on the operating table, the physician doesn't know, is it because they didn't do a good enough job or is the patient just really sick? Um, and so they were able to do the study where they showed these cardiac surgeons how they were doing, right? Like what was the predicted mortality rate of their patients versus the actual mortality rate of their patients. And what he found was the physicians that weren't doing well, once they knew that they weren't doing well, actually put in, I guess, the effort. I mean, we don't really know how they did it, but they actually reduced their mortality after like being shown these report cards. Interestingly, even the ones that were doing well also reduced their mortality. The ones who didn't were the ones who were sort of like you're predicted was just what was actually occurring, right? So it seems like there was both the hey race to be better for those at both ends of the spectrum. But I think it ties to this idea that letting doing this kind of study at an individual level and say, hey, here's your I don't like the term report card, but here's your accountability tool. Here's your dashboard on the differences in care you're providing to potentially different people, whether it's based on race, whether it's based on gender, whether it's these power dynamics, may give people the tools to be like, oh shoot, I need to think about that when I'm actually treating these patients, or think about how the decisions that I'm making. So I think across the board, all of these can play a role and are important. But there is no one silver bullet, unfortunately.
Oh yeah, thanks. I love this going over this again. But and the other thing I can think of is like, well, algorithms different than AI and
Mhm.
machine learning algorithms, but maybe to help identify patterns in chart notes and
Sure.
medical images. Other thing I can think of.
Oh yeah, yeah. And I mean, yeah, I mean we have a lot of health IT ability, right? So um just like I see somebody put in the chat, like the report card real obvious patterns, right? You could also do this with exactly these could be, two parts of the same thing that's part of this report card or accountability tool that shows, okay, yeah, these if we look through the notes and do some text analysis, oh, by the way, we get a lot more text when the patient is of whatever category, if they're higher rank or whether they're, African American or whatever it is. And that could be really informative.
Thanks a lot. Go
Thank
Army.
Thank you, Kevin. So, yeah, Bob, would you like to read some questions of Soma on the room chat?
Sure thing. Thank you, Cecile. Soma asks, how are decision makers using your research?
Yeah, excellent question. One that I don't really have an answer for right now. So we've sent this research into Defense Health Agency, and yeah, I did receive a response. So I will say one thing: the military empowered me to conduct research on variation in care, and they funded several grants for me to be looking at these things. So they are interested in knowing the answers. This wasn't, and this was part of some of the issue with some of the reports that came out. This was not a gotcha on the military at all, right? The military is asking me about this, and I had talked with several senior leaders as we were doing this research. Now, what are they implementing to do with this? I don't know that yet. Just there's a lot of things going on politically right now with the military, and so I think I'm hopeful that I'll have conversations going forward, so I can know a little bit more about what they're doing. But I do think that they're interested in ensuring that care is fair and equal across the board, or fair and equitable, I should say.
Soma has a follow up comment. She states that it's great. What has long been reported by patients as deadly bias is now being validated via research. So, this is a heartfelt thank you. And
Thank you.
I'm a Navy brat, so I relate to a lot of this.
Yeah. Yeah. Yeah, I do think it's important. So I appreciate that comment. And that was a lot of what we were thinking about too, right? Is that, yeah, okay, we've got a lot of anecdotal evidence. Can we show it in the data? That this isn't just, selection into who's getting a microphone, but this really is going on.
Yeah, thank you, Bob. And I would just like to comment as regards to the use case of the study. For example, only for example, if I'm a hospital director, I think this kind of data or information would be very important to me. If I were to become a good hospital, I will try at least to become a good hospital director,
Mhm,
because basically it refers to the management of the whole system of the hospital.
mhm.
For instance, there are studies on how to like operate the long line, or how to treat as many patients as possible if there is a shortage of doctors in emergency rooms. And this is one area that I know that has been, well, one of my friends made
Mhm,
this particular study, because basically, yeah, I have a big circle of people on doctors actually on the field. And I mean, in my among the colleagues that I have, so they, even those who are getting higher ranks, try to think
mhm,
about how to manage the hospital. Or initially, of course, if you are assigned to a higher position,
mhm,
you will think on how to like open close quotation, honestly try to manage these situations. And I think this is very helpful to, in order to be able to manage that, and to start a discussion on how to provide solutions, or at least try to mitigate
mhm,
the situation. You need data from what you had done in your study, I think, not only in the military but universally.
mhm. Yeah, agree. And again, my take on this, both within and without the military, is most people involved in healthcare care about providing healthcare. And again, you're always going to have certain bad players, but most people are very dedicated. And certainly my experience in the military is that most of the healthcare leaders, well, I would say, nearly all of the leaders I met throughout my time in the military were dedicated to taking care of people. And want to do what's right. But that's, there are complications, and we're human and we have human failings. Um, I had another comment and I think I lost my train of thought. Oh, yeah, in and without of the military, I would like to see this type of study replicated in the civilian world. I do think it's challenging to do this type of analysis in the civilian, simply because of the lack of um, power. Now you can do things like like wealth, but there are just so many other things that go along with wealth that make it very, very challenging to study. But I'm sure there's ways, right? We've got a lot of brilliant researchers trying to think about these things, and I'm excited to see, what comes next.
Yeah, so um, I think just like what you're saying, that the solution would not be immediate. It would take generations, and
Mhm.
probably the solution will not really be absolute, because I think if they say it takes a village to raise a person, so
Right.
yeah, I think there is, the cultural innuendo that is here within, because of course this is a study all over US, but if you look at other cultures when we were like kids, for instance, we see how people are practicing, and maybe even if we have a desire to be fair and to really take care of people, we could not try to dispel the biases that we had acquired as children as
Mhm.
we grow up, and sometimes without thinking we automatically try to make decisions or do some actions based on the culture that we have.
Yeah.
So one of the undergrad courses that I had was in political science, and I tried to make a study in Asia, for instance, about the prevalence of hope about having communism. And I would say that one of the failures that this was that why it did not succeed in some countries in Southeast Asia, like for example the Philippines, for instance, is because the
Hmm.
socio-political culture that they have is that there is what you call vertical integration from the
Hmm.
history of feudalism that has been there, brought during the Spanish time, wherein the loyalty of the people are not based on the kind of the same socioeconomic level that they have, but on the based on the landlord or feudal lord that had handled them. So it was difficult to do that kind of recruitment, even if we feel that some people are oppressed in poverty and they lack so much power, because basically their loyalty is to their landlord or to the don, or the padre that they have on that. And
Yeah.
so I think it stretches out also even up to this day to the levels of relationships that we have, not only in the hospitals but in any other organizations. So yeah, we could see that people will automatically try to look up to people who have power. For instance, say, for instance,
Hmm.
a senator came in, and yeah, they have to treat that, because otherwise they will have some kind of bad press, because people who in power are also abusive in general. So, uh, yeah, that's what I would like to say. It's a very complicated kind of network relationship, I think.
Yeah. I mean, what I would say, yeah, I mean, I don't know if, if most are or not. I mean, I'll leave that. But what I would say is that culture matters, right? And so if you think about running a hospital that has a large, um, or I'll take, like, I work at University of San Antonio. UTSA is a Hispanic serving institution. It doesn't mean all our students are, but we have a very high proportion of first generation of college and Hispanic students. And the culture in that type of environment is different than the culture when I was at Penn in graduate school, or at Baylor, which is a Baptist university, and then how you think about how you can relate to people really does matter, right? Things like how close people are with their families, right? Different cultures have different levels of family, and then you can think about things in healthcare, like, are there language barriers, right? Are we going to, does somebody have to bring their daughter to translate? Like a close friend of mine who's a Romanian immigrant, and she has to always go to the doctor to translate for her mom, and gets really, they both get tired of, hey, I've got to repeat the same thing through a translator multiple times to different providers. And so, how do we think about, arranging our care so that whether you are from a different country, speak a different language, have a different level of education, um, come from a culture that may be more respectful of seniority versus others, that we still all get this sort of equitable level of care, and that we're working through things like shared decision making, right? So, if you're from a generation and a cultural background where you just sort of do what the doctor says, maybe you need the doctor to be working a little bit harder to draw out like what do you want, versus if your patient population is sort of the younger, maybe wealthier generation where people are just used to sort of speaking their minds. And so I think there's a lot of work to be done on how we think about navigating these like natural human differences and these cultural differences, in order to get everybody this sort of optimal level of care.
Yeah, thank you, Steve. I just want to ask you if there is a follow-up study on the study that you made, because I understand you were already involved, as far as I saw, based on this particular topic. I think I saw at least two papers that you were involved in.
Yeah, so I am working some follow-ups up that's not out yet. I think the one you linked to was actually it was the editor talking about our study, so I didn't actually write that one. We are thinking about some potential ways to go forward. I have another paper that deals also on relationships in the doctor-patient relationship. But it's more along the lines of trust than it is on power. And that was just accept publication, so I can send anyone who wants it. That's on disruptions to the patient-physician relationship and the lack of how those interpersonal relationships affect care. Uh, I'm also starting to think about follow-on studies, thinking about how these disparities between, say, somebody's supervisor and them leads to maybe differences in evaluation reports, right? So if you think about who gets promoted in a military context, a lot of that has to do with the fact that somebody has stronger or weaker evaluation reports. And one of the things the military has done is they've tried to block out names and pictures from these evaluation reports so that these boards just look at the person's success or failures in their job and don't take into account things like race and gender. However, if you think that the person is getting a better or worse evaluation report based on sort of the level of maybe socio-cultural differences with their boss, then that could potentially already be entering into these disparities in who gets promoted. And so, just some very, very early stage work trying to look at that I think is the most natural follow up to this particular study, although that's not necessarily within healthcare.
Yeah, thank you. So please don't forget us when the paper is going to be released. We would like to
Sure.
invite you, because this is very interesting, and bringing awareness into this conversation that we have. And yeah, these are really important studies for everyone. So I'd like to ask Bob if there are some comments or questions that are on the room chat that he would like to read.
Well, basically, it's a couple of comments complimenting you on the presentation. Um,
Thank you.
Yes, so I would like to inform our audience that this replay will be um, will be on YouTube, and I think Bob will try to sync the um, presentation, the slides, with whatever Steve is saying. So please watch for this YouTube replay that we will be publishing. So, Bob, is it okay to ask you and invite our audience in the YouTube channel?
oh, sure thing. If you go to YouTube and you search for Quantum Photonics Club, will be the first hit you'll get. And right now we've got about 30 little movies.
So, yeah, Steve, I think we've been here for 1 hour and 23 minutes so far. And I would just like to also ask you at least one question. Were there, when you made this study, you told us that they just ask you to give this data, but in your opinion, what, based on the study that you have, what changes would you like to see in the healthcare system to promote a more equitable distribution of resources and care based upon your study? Yeah,
Yeah,
only an opinion.
so yeah, so that's a great question. That's a broad question. There are a lot of changes that I would like to see. So one, we mentioned this earlier, and I think is the hardest is I would like to see a lot more diversity within our provider staff. And again, this isn't necessarily the military. This is just in general that I think um, we lack that, and I think has major implications for trust and communication within the doctor-patient relationship. Um, I think I would like to see more analysis of how we're treating our patients, whether that's the the ideas that I've thrown out, whether it's text analysis or whether that's looking at outcomes. I think there's a lot of room to work on this so that people are more aware. And then, I think it's really important this isn't really necessarily tied to this study, but some other stuff that I have. I think we need to do um, a lot more investment. Well, two things. One, listening to patients. I think oftentimes our providers get really busy, and this goes back to the fact that we just don't have enough physicians. But they don't necessarily spend the time always, or not every physician can spend the time that they need to listening to their patients. And as great as electronic health records are and health information technology, I think too often we're burning our physicians out with everything they need to notate, and that's coming into the relationship because people aren't looking up and making eye contact and actually listening to some of the things that are going on. And then just based on some of my other work, I would like to see a lot more investment in primary care and preventive medicine and in enhancing the doctor-patient relationship. So I mentioned this other paper that I'm happy to share that deals with continuity in the primary care provider patient relationship and how that incorporates information and not having to repeat yourselves and trust and just this level of communication skills that comes between people who know each other that I think is really important for how we think about what healthcare can and should be. While noting that there's always going to be a certain level of churn and people need to have choices. But there are things we can do to make people feel heard. And that's going to have some major implications, I think, for their ability and their willingness to take on preventive care and prevent some of the worst downstream outcomes. I hope that answers your question.
Yeah, yeah, thank you. These are really very noble trust, and I believe in that because generally, I can speak for myself and some of my friends and family. Of course, we would always like to go to the same doctor. Sometimes they could not immediately give us the
Mhm.
solution because there are specialists on the line, but we feel very comfortable if we run to our primary doctor basically, and if we feel sick or we have some doubts or questions about our health, there is some kind of a placebo effect that we feel just talking to them, and that's, I think, how different is an actual human doctor with an AI, because I recently there has been a lot of processes in the medical practice that was an issue of
Mhm.
discussion that the AI will be taking over. So the big difference is that the human doctor that we run to still has empathy. They know us, and we can talk to them, and we trust them. So that is, I think, a very good, an important factor. So I would like to wish you all the best for this coming studies that you have, and please don't forget us. Please be our
Yeah.
guest speaker again.
Thank you. Thank you so much. And just one last thing, I put in a paper that somebody might be interested in. It's called Instant Replay, a quarterback's view of care coordination. That it's just one doctor's anecdote about coordinating care across a bunch of specialists. And I think it really ties into this importance of that relationship. But yeah, thank you so much for having me. This was really fun, and I look forward to doing it again.
Yeah, thank you so much, Steve. And yeah, we really look forward to having you with us again. And probably in the future, I will be inviting you to the other forums, which are doctor dominated, because I think this is very important for them. So, yeah, good luck. And yeah, I'd like to ask Bob at this point if he has something to say before we request Darcel to help us close the room.
I think, on behalf of everyone in the audience, this has been a spectacular discussion, and I really am going away with a few things to think about, which makes a great night for me. Thank you, sir.
Great, thank you.
Yeah, I just want to add that, people like Steve who are making these studies, they give us some hope, and because we see that this is being paid attention to. And I think this is very important. So, yeah, I'd like to thank him again. And now I'd like to give the mic to Darcel to help us close the room. Please check out our platform. We have a lot of rooms this July because several people had postponed the events here this June. Probably we will still have a newsroom before the month ends, but in July we have many subsequent rooms. So thank you so much, everybody, for listening to us and for your continued support. And we'd like to give the mic. Thank you, Kevin, who is on stage, always supporting us. And we'd like to give the mic to Darcel now to help us close the room.
Thank you, Cecile, and thank you, Doctor, for a great room. To close the room, we're going to start our countdown from lucky number 5. Is everybody ready?
Ready?
Ready.
Ready.
5,
Five.
5.
Kevin 4,
4.
Bob Thrice,
3 it is.
Cecile Dos Equis.
Dos Equis.
Doctor, you're number 1. Call out our last number, please.
One.
Yeah, thank you, Steve. We hope to see you back in Quantum Photonics. And to everyone, see you in our next rooms. Good night.
Thank you.